warning when it's about to come to the end of the 3 minutes, and then I think there's 2 minutes for questions after each presentation.
Yeah. Okay, so Roger, do you want to do your poster? We did have Roger, didn't we?
You'd think I'd know, wouldn't you, by now? This is based on a study that was done by Ebony Brown. Unfortunately, her internet has crashed, so I'm stepping in for her. I was her supervisor for what was an undergraduate project. And the focus of the work was to help increase access opportunities to education, understanding and engagement for mainly women who are the largest sufferers of chronic urinary tract infections. UTIs are one of the main reasons why people go to primary care, and for some people, unfortunately, it can result in very serious consequences and for some people lead to their death. It's also extremely mistreated, and traditionally it has been one of those conditions where patients have just been given antibiotics even though there hasn't been any clinical need. And this is especially a problem in nursing homes, and generally UTIs are poorly dealt with by the NHS and others. So what we wanted to do was develop some better resources for people, and we worked with the charity as well to learn from the types of questions Antibiotic Research UK were getting on this topic. And Ebony developed a relatively, well, it was an easy to use online learning package which took anybody, it was open to the public, which took people through the main stages of what a chronic UTI is, how you might know if you've got one, some of the ways it can be treated, self-care, routine care, and when and how you need to seek help. It was evaluated using an opportunistic sample that was gained by a message simply put on social media, and the timescales given for her project, she was able to recruit 18 people, but I'm sure if she would have had more time, then we could have recruited more people. They were asked to access and use the online resource, and they were given some standard questions at the beginning about their knowledge and understanding of UTIs, and then similar questions were asked of them at the end. We also wanted to know how accessible, how the level of usability was of the resource. Was it easy to understand? And was it something that they would recommend to other people?
30 seconds, Roger.
Thank you. As you can see from the results, there was a massive impact on knowledge. You may expect that, seen as a pre and post intervention for the evaluation, but still it suggests that it was an effective resource from that way. Usability was extremely high, and just about everybody said that they would refer it to other people. So in conclusion, we know already that people need better access to information for conditions that can be better treated by themselves, to ask questions of their healthcare practitioners. And we know that online resources and information are increasingly being used by people. So this is a resource that we're going to further develop, and hopefully our next steps are to get it translated into some core languages in the UK and around the world. Thank you.
Thanks very much, Roger. Do we have any questions for Roger?
I think there was one question in the chat saying, how do you raise awareness that this is available, or is it available to the general public?
It's a really good question, and you know, we can develop these things and they can be perfect, but then we've got to actually make people aware of them. We are going to market it on social media, and it's going to be hopefully signed off to be included as a resource by Antibiotic Research UK. We also ideally want it to be given out as some sort of QR or online link for patients when they attend primary care and they're diagnosed with a UTI. And I think that there can be some form of automated way. Ideally, would like to have a QR code put on their treatments that they're given. And then it's just going to be more of a snowballing effect. Leaflets in pharmacists would be brilliant if we could get some funding or for some support for that as well.
There's one more question for you, Roger, as well. This is particularly a problem in the elderly population. This would be invaluable to be included in the NICE guidelines.
Well, wouldn't that be fantastic? And it'd be fantastic for Ebony. She's produced, for an undergraduate student, this is an amazing piece of work. I think what we need to do is to get some funding next so that we can do a larger scale evaluation through a randomized controlled trial, for example, and then hopefully it could be put forward for patient information for the NHS and to be included in guidelines by NICE. But the next steps would be to do a more rigorous evaluation of it.
Brilliant, thanks very much. Any more questions for Roger?
No more questions, but thanks to Deb Kumar for that question.
Thank you.
I've got to say who asked the question then, sorry.
Thanks very much, Roger, for that. It's okay, so we'll move on to the next presentation. So we've got Naomi. Do you want to do your poster, Naomi?
Yes, thank you very much. I think we're starting off with Beth.
Yeah, should I start now?
Okay? Yes, please.
Yeah. So just a quick introduction. We're all first year medical students at Manchester, and we really appreciate the opportunity to speak here today. Thank you. So HPV or human papillomavirus, it's the most common sexually transmitted disease. And the HPV vaccine was initially offered to girls as a prophylactic treatment for cervical cancer, but it was later realised that the vaccination programme would actually be more effective if boys were included as well. So HPV transmission occurs through skin-to-skin contact, mainly through penetrative intercourse, but it can also be spread through hand-to-genital contact or from one area of the genitals to another.
Damage to skin cells or keratinocytes in the anus facilitates HPV infection. Late HPV proteins L1 and L2 aid HPV entry into host cells, and early region proteins are involved in the assembly of and release of mature virions from the keratinocytes. And these are E1 to 7, and then E5 to 7 are involved in the carcinogenic process. The high-risk HPV subtypes are associated with anal cancers, particularly HPV 16, and that's present in 66% of all HPV-associated anal carcinomas. And the most common type is squamous cell carcinoma. Early stages of anal cancer may be associated with symptoms such as benign lesions, anal fissures, hemorrhoids, pain, and loss of bowel control. And a mass or growth in the anal canal may occur at later stages.
The current vaccines for HPV make use of virus-like particles which mimic the viral outer shell to induce an immunogenic response. So the two main vaccines right now are Cervarix, which is bivalent, so that means it protects against HPV 16 and 18. And the other main vaccine is Gardasil, which protects, it's quadrivalent. So as well as protecting against HPV 16 and 18, it also protects against HPV 6 and 11. Now, due to the vaccine program, HPV is commonly associated with women and cervical cancer. And as a group, we wanted to explore the ethics around the lack of vaccination for young boys and the impact this has on high-risk groups, such as men who have sex with other men, or MSM. So HPV is responsible for 88% of all anal cancers, and this is especially prevalent in MSM and men living with HIV.
30 seconds to go.
Vaccinating the female population against HPV, although it was cost effective, it did not fully protect men, especially the MSM community. There's an equal risk of HPV infection in all genders, so it's unethical to discriminate on the basis of gender, sex, and sexuality. Another ethical issue that we came across is that herd protection varies according to socioeconomic area. 1 in 7 girls are unvaccinated in lower socioeconomic areas, and this negates the indirect protection to men. Vaccinating only girls gives the misconception that HPV only affects women, creating a stigma and the belief that only women transmit HPV. Girls carry the vaccination burden to indirectly protect the population from HPV infections. A gender-neutral vaccination program offers greater protection to all genders and an equal responsibility.
The current gender-neutral vaccination program has the potential to reduce the risk of men becoming infected with HPV, and it may also reduce the incidence of HPV-related anal cancers. We thank you very much for listening. We hope you found it interesting.
That's great, thank you very much.
you.
That's a really interesting presentation. Do we have any questions for Lorna and her colleagues? And Naomi and her colleagues, sorry.
There is a question in the chat from Alex. I can just ask this to you. It says, great talk, guys. Do you think there's a case for extending the HPV vaccine to older males who are in an at-risk groups, such as MSM, immunosuppressed?
I can take that one. Yeah, I think there is some movement towards vaccinating, well, men of any age who come into a sexual health clinic and who are men who have sex with men. So there's already sort of steps in that direction. And there was a pilot study, I think, in 2016 that did just that. And the success of that meant that people, they started to it over more cases, I think, really. So yeah.
Yeah, just to add to that, I think just off the top of my head, I think it was introduced in 2019. They started vaccinating, I believe it's men who have sex with men over the age of 45, I think, but that could be wrong. I'm not 100% sure.
I think that's right, but that's people attending sexual health clinics as well.
Yeah, that's great. Thank you very much. Okay, move on to the next presentation. Thanks very much for a really interesting presentation.
Thank you.
Thank you.
So next we've got Laura Flintham from the University of Manchester.
I'm presenting with Donna today. She's starting.
Okay.
Hi everyone, thank you for having us. So until the early 20th century, infection was the leading cause of death in humans, and as we all appreciate, antibiotic therapy has been such an important discovery, improving outcomes for patient health across the globe. However, antibiotics, despite being really marvellous at working to tackle infection, are also adaptable to their environment. And we now know that overuse and incorrect use and prescribing of antibiotics has led to the development of antibiotic resistance. The result is that antibiotics are no longer being as effective to treat infection, and this is becoming a serious public health concern. Anybody in public health can play a key role in the drive and stewardship towards antibiotic resistance, and one of the most notable campaigns is the Antibiotic Guardian. As part of our MRES, Lorna and I have been chosen to provide service evaluations in collaboration with the Antibiotic Guardian campaign. For my quantitative contribution, I developed a 17-item online questionnaire which was distributed to around 5,000 pharmacy professionals that pledged during World Antibiotic Awareness Week during 2019 and 20. In addition to general evaluation around how the campaign had supported stewardship in terms of behaviour change, knowledge and capability within pharmacy, I had particular interest in how changes to pharmacy policy has influenced pledges, as in 2020, the Incentivised Pharmacy Quality Scheme added antibiotic stewardship to their requirements. The survey only closed last Friday, so we're still awaiting our full data set, but early results show that almost 80% of pharmacy professionals have dealt with antibiotic prescribing in the last week, so it really shows the value of such campaigns. And interestingly, despite there being a much higher cohort of pledges once the policy change took place, only approximately 10% more have reported completing the campaign as part of mandatory training, and many more have pledged through having their own interest in stewardship, which is really encouraging. Over to you, Lorna.
So my side of the research has been qualitative. I've done semi-structured interviews over the last month or so with 10 antibiotic guardians, and it's been a pleasure to hear about their attitudes towards antibiotic use, illness and AMR. I used a topic guide to cover various different areas of questioning and use Zoom to record the interviews. I'm still in the process of analysing the 100+ data pages of Baton data at the moment, but a few preliminary themes have popped up. So firstly, there's a strong idea of personal responsibility. So each of the guardians that I spoke to had a strong sense of personal responsibility towards behaviours that are in line with the AG campaign and conducive to tackling AMR. And it was usually these pre-existing interests and behaviours that allowed people to come into contact with the campaign, either through online searches or through public events. And
30 seconds to go. Sorry.
Involvement in the campaign usually cemented and confirmed their pre-existing antibiotic-related behaviours, rather than creating new behaviours post-pledge. There was also quite a lot of frustration amongst the antibiotic guardians on two levels, both towards primary healthcare and prescribing and on a national level in terms of communication with public. And then finally, there's this idea of shifts in attitude as a result of COVID-19. And again, this is mixed, with some antibiotic guardians not changing their attitudes or behaviours at all. And then in other cases, they communicated that the fear associated with the pandemic has pushed them to really evaluate how we use antibiotics and the fear of AMR. And it is hoped that all this data, along with Donna's data as well, can be fed back to Public Health England to augment an already successful campaign. Thank you.
That's great, thank you very much. Do we have any questions for Lorna and Donna in the chats? Nothing in the chat.
There's nothing in the chat, no.
Okay, no. I've got a quick question. Did you identify any areas where sort of further research was needed? Any areas sort of further research questions?
I think there's definitely further research needed in terms of how we, from the public side, from my side, the public side, of how is best to communicate with them with the campaign. People would often come up with the problems with the campaign, such as it only contacts people at one point in time and then they kind of forget about it because they're not contacted again. But I think there's more research needed to know how exactly we can use that in applications in the future, I think.
Brilliant, thanks very much. Okay, that's great, thank you. We'll move on to the next presentation. I'd like to introduce Abarisha Gajuri from the University of Vellore. Hi, Abarisha.
Hi.
Hi, would you like to do your poster now?
Yes.
Okay, go ahead.
I have Is this okay?
We can hear you.
Yeah, we can hear you.
Yeah, okay. Hello, my research study refers to knowledge and practice of surgical site infection among surgical nurses in hospital care of Albania. As we know, the surgical site infection are one of the most common types of healthcare associated infection, which are considered 20 to 25% of all the healthcare associated infection among surgical patients in different institutions. And nurses can play an important and a key role in providing quality care and in prevention of surgical site infection. The objective of my study is evaluating the level of knowledge and practice of nurses in my hospital of care in Albania and associated factors regarding prevention of surgical site infection in different surgical units in this hospital, and to determine which are the relationships between these factors. We know that World Health Organization has set important and a number of recommendations toward prevention of this surgical site infection, and nurses play an important role of implementation these guidelines. For example, in preventing their patient from this infection and promote the health of patient. This recommendation can conclude the avoidance of preoperative hair removal or advice for preoperative showering, hand hygiene, appropriately and timely administration of antibiotics, pre and post-operative glycemic control in this patient, and wound management, and the nutritional assessment and surgical site preparation. My study is a cross-sectional descriptive study and included 41 selected nurses, who completed an anonymous questionnaire containing socio-demographic knowledge and practice related questions to measure their level of knowledge and practice, and how which are the associated factors regarding this infection.
30 seconds.
Yeah,
Sorry.
the results have shown that majority of nurses, 66% have average knowledge and good practice, 49% regarding the prevention of surgical site infection. We have concluded that different factors, sex of participant, work experience, age, educational level, training, and the prevention guidelines are significantly associated with their nurses' knowledge and practice. And we have also found statistically difference between knowledge and practice of nursing. In my poster presentation, I've also showed the figures about the distribution of nurses' knowledge and practice. And this research study, I have concluded that nurses have a good practical level of infection control, but knowledge was found at level of average. I recommend, this result recommend an increasing level of knowledge in training nursing, in focusing nursing in some certain areas of prevention of surgical site infection. And I think that the healthcare institution should promote and should apply in different institutions program trainings for nurses, also to improve their level of knowledge and practice on this. Is very important for the nurses to implement these important guidelines for the World Health Organization. That's all about my poster presentation on my research study. Thank you.
That's great. Thank you very much. Do we have any questions in the chat there?
Yeah, there's one question from Lorna. And she says, have you identified any barriers to improving knowledge among among nurses?
Yeah, yes, we have found. I myself, during my period of study, I have found different barriers. For example, nurses, as part of an institution, they have no. How I can say, the institution, the healthcare institution, they cannot apply this. They have not the opportunity to apply this recommendation, and also to apply in practice this knowledge, and also their improve their level of practice.
Yeah.
Thank you.
Okay, great. Thank you very much.
Thank you.
Thank you. Okay, so now we'd like to introduce Alex Hayes from the University of Oxford. Would you like to do your poster, Alex?
Yeah, thank you very much. So, hi everyone, my name is Alex. I'm a fifth year medical student at the University of Oxford. Today I'll be talking about this project that I did as part of my final honours school year in 2018-2019. I carried this out in Peter Simmons' lab at the Peter Medawar Building of Pathogen Research in Oxford. This involved testing the sensitivity and specificity of PCR assays for enteroviruses, which were used by other labs in the European Non-Polio Enterovirus Network, or NPEN, which in turn is part of the European Society of Clinical Virology. So we created highly purified RNA transcripts of the genomes of 5 selected enterovirus species that often cause infection. And our findings are published in 2020 in the Journal of Medical Virology. So taking a step back to think about enteroviruses in general, they're a very common genus of viruses and cause a wide range of symptoms, Many are asymptomatic, but they can cause mild gastrointestinal or respiratory infections up to more severe meningitis or sepsis. So we produced highly purified RNA transcripts of 5 selected enterovirus species, including enteroviruses 71 and D68, which are emerging recently in Europe and can cause more severe infection. These are sent out in coded sample bottles to reduce bias at 2 concentrations to the NPEN labs. And they then use PCR assays to both screen, i.e. look for any presence of enterovirus, and type, i.e. find what particular strain of enterovirus is present in each sample. They also use commercial kits versus their own in-house primers and compare results. So overall, we found that the assays were quite good at detecting or screening for enterovirus presence, but they were less specific in typing which type of enterovirus was present. We also found that the commercial kits were significantly worse performing than their in-house assays that the labs used. We looked into why this might be the case, and we compared the sequences of the primers used by the labs compared to the part of the enterovirus genome that they bind to, which is the 5' untranslated region. And we found that often the worst performing kits had many mismatches to the region, leading to worse binding and poorer detection at the higher concentration. So the labs within NPEN now have these molecular standards, the RNA transcripts, which they can use to evaluate the sensitivity and specificity of any PCR assays they use in future. This will allow improved monitoring of any future enterovirus outbreaks across Europe. And from a public health perspective, I think the experiences of the last 18 months show the importance of being able to quickly and accurately identify growing viral outbreaks. So this will allow improved PCR assays. Sorry, is that 30 seconds?
30 seconds to go, yes, sorry.
Thank you. This will allow in future improved PCR screening and typing across Europe, and will therefore allow Europe-wide cooperation to monitor and identify emerging outbreaks of viruses such as EV, D68 and 71. So thank you very much for your time, and I'd be happy to take any questions.
Thank you very much, Alex, for another very interesting presentation. I can't see any questions for Alex in the chat. Do we have any questions for Alex? Just wondering, Alex, how this research is going to be disseminated. How will you disseminate your findings?
Absolutely. So the findings are kind of relatively well known within NPEN, and the labs that kind of take responsibility for screening, typing for these viruses. I think kind of public awareness of enteroviruses and the infections they cause and how severe they can be is slightly lacking. And I think perhaps this research is not a very good kind of starting point for that kind of thing. It's quite technical in nature. So I think perhaps a kind of broader public awareness campaign about enteroviruses and about other emerging respiratory viruses could be useful.
Definitely, yes. Brilliant. That's great. Thank you very much.
Thank you.
Thank you.
Okay, so now I'd like to introduce Emil Nagubo from Oasis Health. Hi, Emil.
Hi.
Hi. Hi. Would you like to talk us through your poster, please?
Okay, thank you very much. Samir Ngabo from Oasis Health, collaborating with Roger Harrison from the University of Manchester. This presentation showcases the 30 days of antibiotic stewardship in Rwanda. As you know, antimicrobial resistance have been ranked among the top 10 global health threats, and as well as economic threat by the WHO. So in Africa, there is a limited awareness of the topic, especially in Rwanda, and it is in this way that we initiated this program of 30 days of antibiotic stewardship in Rwanda, which is a social media monitored campaign to raise awareness about the antimicrobial resistance. The methods we used, it was a Twitter managed competition that aimed at raising awareness of antimicrobial resistance, especially antibiotic in Rwanda. So the general population was requested to do the course on antibiotics, which is called Antibiotics and You, designed by students from the University of Manchester, called Antibiotics and You. And each competitor has a tweet on which he had to mobilize the community to do the polls and reply the tweet with their certificates and continue mobilizing the other population to upload their certificates on the tweet of the competitor. And the competitor, to win the competition, was required to have at least 100 certificates from the mobilized community. This competition was of 30 days, and it included different activities of raising awareness, including poster sharing on social media. The results of the project, 7 competitors have managed to join the competition. 326 people have clicked the link. 201 people have participated successfully in the competition. And we had around 14K impressions on social media. 4 youth-led organizations have approached us so that we can partner or to do many awareness campaigns, and it was followed by the World Antimicrobial Awareness Week, which we partnered with about 5 youth-led organizations.
30 seconds to go.
The winner of the competition was a 4th-year medical student who mobilized 115 people. Conclusion: simple public engagement activities monitored under social media can be cost-effective, and this approach is highly recommended. Again, it is strengthened partnership among people in Rwanda, among different youth-led organizations. Thank you very much. That was my presentation. I'd like to receive questions.
Thank you very much for another really interesting presentation. Don't think we've got any questions in the chats at this point, but we can always come back for more.
Yeah, there's no questions in the chat, but I just wanted to say that I actually worked on this project on antibiotics in you, and it's great to see how it's been used in other places and really creatively with the Twitter campaign. And congratulations as well. It's been really, it looks like it's been really, really successful.
Okay, thank you very much.
What are the next steps, Emil, for the project in terms of dissemination, or is there any further research going to be going on?
Sorry, can you please come again?
Sorry, what are the next steps in terms of how the research will be disseminated or any future research?
Okay, so we plan to do another session annually, annual sessions of the same project, raise awareness in Rwanda. And we also plan to do much more research about the topic, especially in the public hospitals about antimicrobial resistance, especially in medical students doing internships.
Great, thank you very much. Thank you. Okay, so we'd like to welcome Theo Welsh now from Hull York Medical School. Is Theo here?
Hello, good afternoon.
Welcome, Theo.
Can you hear me okay?
Yeah, I can hear you.
Okay, perfect. So hello everyone. My name is Theo Welch from the Hull York Medical School, and with my supervisor, Dr. Hidden Faker from the Hull University Teaching Hospitals NHS Trust, I did this research as part of my degree. So as I'm sure we're all aware, HIV progresses to AIDS if not treated with antiretroviral therapy, ART. Convenient and less toxic treatment regimes in recent times have improved HIV treatment considerably, but there's still limited data available on why patients may not be initiating ART since these improvements. So this study done by myself and my supervisor hopes to understand why individuals in the Humber region with a HIV diagnosis are not on ART. So this was a retrospective case series using patients identified cross-sectionally. I used Castle Hill Hospital's electronic health record to identify the individuals in the Humber region who had not initiated art. These were all males and females aged 18 and over with a HIV diagnosis. And then I went through all their case notes, and their reasons for not initiating art was analysed qualitatively. So in the Humber region, there were 537 patients with a HIV diagnosis. That is 0.05% of the population in the Humber region. And 4 of these patients have not initiated art. That's 0.74% of the cohort. So compared to other syndromes, such as diabetes and other chronic conditions, patient readiness to initiate art seems to be related to internalized health and treatment beliefs, as opposed to things like the fear of side effects and difficulties in managing medications. For example, one patient stated that not taking art allows me to forget my HIV diagnosis, as I'm afraid of stigmatization. In 2019, the UK had a HIV prevalence of 0.15%, and 98% of these patients were receiving art. The Humber region was actually more successful, as 99% of its patients are on art. This is something that could be explored further. So in conclusion, I believe that a more patient-centered approach is needed to support patients who are resistant to receiving art. Now, because of the changing guidelines, more individuals are initiating art before ever having experienced signs and symptoms. Therefore, the public health risks of incompliance may actually be greater than ever. I believe we should assess adherence and maybe provide pre-treatment counselling very early on in their diagnosis, using a more multidisciplinary team approach. Future in-depth qualitative interviews could explore this further, and by speaking to these patients and assessing their actual reasons why they are not receiving antiretroviral therapy. Thank you very much for listening. Please feel free to ask any questions.
Thank you.
Thank you very much, Theo. Do we have any questions for Theo? Can you tell us a little bit about the next steps? You mentioned doing interviews.
Yeah, so I'm in discussion with my supervisor. Hopefully next year, pending ethical approval, I could do more in-depth qualitative interviews. So obviously this data is completely from their case notes. So if there would be the opportunity to discuss their reasons why they are not receiving antiretroviral therapy, I believe that would be very useful. Also expanding the study size, as obviously it's a very small sample size. 4 patients were not receiving antiretroviral therapy, so if that could be expanded, we'd be able to have more data which could be analysed, which of course would be better as well.
Thank you. We've just got a couple more questions in the chat as well. Somebody's asked, is the prevalence based on tested people?
Yeah, so the prevalence, obviously the prevalence in the Humber region, that is based on tested people. Obviously the prevalence is always, will be slightly higher. So obviously the United Nations 1990 target, that was based on, they believe 90% of those patients who have HIV have been tested as positive. So it's likely that the number of patients who actually have HIV is higher, but that statistic is those that have been tested positive. Yeah.
Thank you. Another question in the chat is, you mentioned the terms of patient-centered approach. What did that mean in terms of this project?
So their reasons for not initiating are probably quite complex and multifactorial. There might be psychological issues, there might be social issues. So really talking to them and deciding why they're not on antiretroviral therapy, and maybe offering more targeted approach using psychologists or getting social workers involved, I believe that could probably really help them to counteract the non-adherence.
Right, thank you very much. Thanks for a really interesting presentation.
Thank you.
Okay, thanks. So I think our next speaker, sorry,
can I just interject? Can everybody make sure that they are on mute? We seem to have a sort of a consistent background noise at the moment. Thank you.
Okay, thanks, Monica. Okay, so I think Rosin Reynolds, you were going to do your share your own poster, is that right?
Yes, that's correct.
Okay, brilliant. So do you want to do that now?
Yeah, I'm hoping that sorry, it won't allow me to. It's saying I'm disabled. Host is disabled participant screen sharing.
Okay, sorry, we'll just get that sorted out. Okay, do you want to try again?
Yeah. Okay, can people see that?
Yes, thanks.
Great. I'm not presenting any research. I'm actually going to talk to you about some changes that we made to an already established program to respond to the COVID-19 outbreak. So we're looking at, I'm the senior advisor for the alcohol exposed pregnancy program in Greater Manchester. To put that in some context, 40% of pregnant people throughout the UK drink alcohol during pregnancy. For a number of those, it will be because they actually didn't know that they were pregnant. It would be during early stages of their pregnancy. And our program is really to ensure that people are aware of the Chief Medical Officer's advice in relation to if you're planning a pregnancy or are pregnant, that you don't use alcohol because of the risks associated with that. So we have 3 spheres to our overall program. We have a prevention, a support, and a knowledge section. And I just want to very quickly tell you some of the things that we did in relation to responding to try and ensure that we continued delivering our alcohol exposed pregnancy during the COVID breakdown. So initially across our maternity pathway, one of the very early things that we talked about was the early data, emerging data reflecting increase in drinking and unplanned pregnancy rates. And we needed to make sure that the maternity services knew about that and that they were actually having conversations with individuals in relation to it. Extra training was put in place for staff who were shielding, as actually they became the first contact via phone or via Zoom, similar to what we're doing now with individuals. We also looked at the barriers that were associated with accessing long-active reversible contraception, because sexual health clinics are closed and GPs weren't doing face-to-face contact. We had a number of midwives that we had actually trained, so we put on additional implant clinics for women who were able to return in their postnatal period. And we delivered over 70 LARCs during the lockdown period. These were to vulnerable women who were at high risk of unplanned pregnancy going forward. We did lots of external training, and there were lots of wellbeing calls to individuals who were struggling with their alcohol consumption and their isolation. And we used one of our partner organisations to actually ring them on a regular basis and give lots of information really about how they could progress. Within Tameside Council, which is one of the areas we work in, we were Tameside, Oldham, Rochdale and Bury. They worked with their 2 major providers, Change, Grow and Live, who were a drug provider, and their women's centres. And they started delivering all of their work online very, very early. They were giving out brief advice. They adapted their prevention program, started running groups. They did an online refresher training for staff, and they did an online awareness training for people across the partnership. And actually they've decided to continue some of that online work because it actually got received very, very well. So our next one, sorry, I'm struggling to. Rochdale, they had designed a local campaign which they put on hold. All appointments very quickly went virtually. The health visitors, a lot of the health visitors were actually redeployed into infection control and vaccination centres, but those that were left had additional training, and they actually carried out the home visits to women that were considered to be vulnerable.
30 seconds to go. Sorry.
The Billboard campaign did go ahead, and the accompanying campaign gained over 32,000 impressions. Okay, so very quickly going to tell you about Dry Mester, which is our main campaign. The biggest thing was there was lots of information out at the beginning that was changing, and all of our assets got done to ensure that what we were saying is that regardless of what was changing about COVID, alcohol guidance was remaining the same. There was no safe time and no safe amount. We also produced some additional assets to help with easing out of lockdown. I'm sure you remember when we were already all coming out of the first lockdown, we all thought that was it. We were going to have a big party, and we wanted to ensure that people who were pregnant could be supported in not using alcohol. Action Together supported all of our support groups. We have 6 support groups, and the parents developed an FASD ebook that is now actually available online with Action Together, and it's parents talking to other parents about accessing education, accessing diagnosis, how to work, how to support children with additional needs in lockdown, and that's been really well received. And the final thing is our prevalence study. We commissioned the first ever UK prevalence study on FASD. Schools were set to close, so we had to go back and get ethical improvement to amend the request so we could start doing the feedback from participants via the phone. Once the schools reopened, we had to do lots of risk assessments to ensure we could go back in and continue with the assessments. Previously, we used to do face-to-face training with the staff, and we kind of developed that into a recorded presentation, which is now available for all schools. The prevalence study has finished. It was done by the University of Salford, and they are actually presenting their prevalence study as part of this public health festival in this week. And as part of it as well, during the period of time when we were in lockdown, we'd had a number of parents that had received a report. So we did a qualitative study of those and went back to them and asked what receiving the report felt like, what being told their child was diagnosed with FASD felt like, and what support the report gave them, and actually how was it useful during lockdown. And I think that is me. And that was it. So that's how we responded.
That's great. Thank you very much. I can't see. Thank you. I can't see any questions in the chat at the moment.
There is one.
There's one.
Yeah, the question's from Lorna, and it asks, in addition to the measures you've discussed, is there anything more that we could be doing to build back better post-pandemic?
Absolutely. Like I said, our Drymester campaign, we've produced lots of additional assets. We have done further kind of digital type campaigns. We have recently launched a film called Birthday, which is specifically for our education, an education resource for colleagues working in education. We had a showcase that had people both nationally and internationally attended in relation to a lot of the pieces of work that we've done. And we're currently meeting with commissioners across Greater Manchester to look at how we move this forward. NICE are bringing out FASD quality standards this year based on the SIGN guidance, which is the Scottish equivalent of NICE. There will be 5 quality standards associated with the first 2 will be specifically around the prevention of alcohol-exposed pregnancies and prevention, and then the other 3 will be around diagnostic and treatment. So the quality standards will be a massive game changer in this arena in relation to be able to take that forward. And we now have our first ever UK prevalence study.
That's great. Thank you very much for a really interesting presentation.
No problem. Thank you for having me.
Thank you. Okay. So I don't know if we got our next speaker, Andrea. I don't think Andrea's arrived yet. You hear Andrea? No, I don't think so. So should we move on to Nupur Chowdhury? Is Nupur here?
Hi, sorry, I am here.
Hi. I think you have your own presentation to share, is that right?
Yes, I did upload it. I mean, in case you haven't got it, I'll try and share it on mine. Just give me a minute, sorry.
Thank you.
You may need to make her a co-host, Kath.
Yes, it's showing that it's disabled at the moment.
Yeah, sorry, I'll just try and make you okay, do you want to try again?
Yeah. Let's have a look. Is that any good?
Yeah, that's great. Thank you.
Okay. So my name is Nupur, and I'm studying MPH at the University of Sheffield. And what I'm presenting to you is part of my policy module as part of the degree. So I would like to speak about the relevance of telepsychiatry in India. So the current mental health in India is quite poor. They have a lot of national and district mental health policies in place, but they're not uniformly implemented due to various reasons. The burden of disease is really high. It's about 10% of the adult population. You're talking about having one or the other form of mental health illnesses. And there's a very large treatment gap because there's only about 0.75 psychiatrists to every 100,000 population. The ideal acceptable one is about 3 psychiatrists, and usually in high income countries it's about 6 psychiatrists per 100,000. So you can imagine how much of a treatment gap it's led to. And on top of that, there's inequities in service provision as well between the rural and urban areas, because the urban areas are much more developed and have better infrastructure, and the specialists like psychiatrists and other mental health staff are more likely to be found there than in the rural areas. So there's a double burden of disease along with poverty and everything that's going on. People from the rural areas actually have to travel to the urban areas to seek specialist help when things are really bad. So the whole relevance of telepsychiatry comes into play over here, especially now in the current COVID pandemic situation. There's a large number of deaths, as you must have already come across in the news in India now in the second wave especially. And there's an increase in incidence of mental health issues. And that's quite obviously expected because people are losing their loved ones, they themselves are suffering. There's basic facilities are not being available at some points. People are losing their employment, their housing. So there is a lot of increase in mental health issues due to all of this going on. So there's an increased need for the health service provision for mental health specifically. So we're talking about already a dearth situation. There's a large treatment gap now. It's going to be even more higher. So this is why I chose to speak about telepsychiatry. So telepsychiatry is basically the use of multimedia technology to deliver mental health services from far. So you can still access remote, inaccessible areas otherwise, like the rural areas and places where you wouldn't be able to access usually. So it can be done in an asynchronous or a synchronous manner. So the asynchronous manner doesn't require a live internet connection straight away. You can store the information, you can take the diagnosis, you can do the questionnaires and everything, and then send them by storage and then email, and then you receive something back.
30 seconds to go.
Or you could do live video conferencing, which is a synchronous way. And this has been done in many different countries. And in India itself, like in telepsychiatry, it is an emerging field, like I mentioned. There are quite a few projects going on, but there is nothing going on in uniform manner all throughout the country. The challenges, there are quite a few, like the lack of political will in prioritizing public awareness of mental health issues, the multiple stakeholders collaboration that's required for something like this to happen throughout the country is required. Plus you have to upskill the mental health staff in the rural areas and make them aware how to use the technology and provide them with it as well. And also the culturally sensitive understanding of the local dialects and how they interpret mental health issues throughout the different parts of India. And also the ethical issues regarding maintaining confidentiality and safe storage of information, which are quite sensitive. And also in terms of effectiveness throughout the high income countries that they have been implemented in have shown quite positive results, but they have been in small sample sizes and there haven't been any long-term evaluations of things. So there is still a need for evidence for the long-term effectiveness of it. And this is why we are bringing this into play, because I think this is quite an important thing in this, especially considering the pandemic and everything that's going on. People will be needing help and we have to look at all sort of modalities of provision for the services. Thank you.
Thank you very much. That's great. Do we have any questions? Don't think I can see anything in the chat at the moment, but we can come back. But thanks for another really interesting presentation. Are there any sort of next steps for this project? Any sort of future research?
At the moment, not much going on because it's part of my module, but I'm hoping to speak to my tutors and see how to get this further ahead in terms of maybe a systematic review or like publishing a paper after some more qualitative studies with people in India and involving them as users as well as service providers potentially.
Yeah, great. Thank you very much.
Thank you.
Thank you. Okay, do you want to stop sharing your screen? Do we have any questions for any of our other presenters just before we end the session? Can't see any more questions in the chats. Okay, well, thank you very much. It's been a really interesting, thanks to all our speakers. It's been a really interesting session. Just a reminder to vote. We'll post the link in the chat one last time. Hope you enjoy the rest of the festival. We'll just keep an eye on the programme in case any other sessions are added. And another reminder that we, if you're tweeting about the festival, the hashtag you can use is PHFest 2021. So thanks to everyone for coming. Thank you.